Hi, my name is Danielle Matias and I'm here at Caring Medical Florida, and I wanted to share with you an interesting hip pain case that I saw recently. So just to orient everybody, these are the main ligaments that hold your hip together. What does that mean? Well, think of ligaments like rubber bands, okay? So these are like the tight rubber bands that kind of hold your hip together and help hold that ball in the socket. Specifically in the front of your hip, you have your iliofemoral ligament. Fun fact, that's actually the strongest ligament in your body, or it should be. Pubofemoral, and then in the back you have your ischiofemoral. Ligaments have a lot of nerve endings. Okay, so this is important for this case because ligaments can actually be a big source of pain, acute or chronic. If anyone's ever sprained their ankle where you actually, stretch out the ligaments in your ankle, that is oftentimes more painful than an ankle break. Again, just because of all those nerve endings that are there. So in this patient specifically, 34-year-old female, she had had a hip labral repair years prior to coming to Caring Medical. She was told, because her hip pain continued and nobody could really figure out why, she was told she may need a total hip replacement. Again, she's 34. That's pretty young. So when we did the physical exam, what I do a lot of times if I say, hey, let's really confirm what is causing this pain, And so I did what's called an interarticular diagnostic block. So what that means is I just took a local anesthetic, just a numbing agent, and I injected it in the hip joint. Okay, so you're thinking like cartilage, labrum, what's going on in there that could be a pain generator. So we did the block. She rested for several minutes for the numbing to take effect, got up, moved around, no pain relief. Still the same amount of pain. So I think, okay, so if we've kind of ruled that out as the pain generators inside the hip, let's block that iliofemoral ligament. Again, big ligament in the front of the hip. When patients have a lot of anterior hip pain, that could be a cause. So again, I took some local anesthetic, injected it into that ligament, let it kick in. Patient reported greater than 50% pain relief. Now, have I done anything to help her, fix the problem? No, but we've confirmed what it is, right? Which sometimes is half the battle when you have this chronic pain that nobody can figure out. So we've confirmed in this hip that she has some ligament injuries, and I recommended that we do prolotherapy to those areas to help heal the ligaments and strengthen them and reduce pain. At her second visit, so she's completed one treatment, at her second visit, she reported 35% reduction in pain and was able to dry her feet off after the shower without pain, which is probably something that a lot of us take for granted, but for her, who couldn't bear any pressure on that leg, to lift her other leg up and dry her foot, that was really challenging. This is her motion x-ray. So in the office, we do what we call a DDR, a dynamic digital radiograph. But we commonly just call it a motion x-ray, where we say, hey, here's her hip, and we have her move it in positions that cause pain or just, positions of normal motion, and take a look. So this video is slowed down about 50% of how quick she was actually moving, but here's her hip, the ball in the socket, and we're looking for several things. Is there arthritis? Of course, we would see that on an x-ray, bone spurs. But we're also looking to see how the joint is actually moving and if there is increased space between the bones, reduced space between the bones. That would help us determine if there is instability in the joint. This is her left side. Okay, so she was having some left-sided pain. We don't necessarily always x-ray the other joint too, but sometimes it is helpful. If you have a painful joint and a non-painful joint, and we're trying to figure out pain generators, sometimes it is helpful to compare the, let's say, abnormal to the normal. So what we're looking at again is this, does she kind of maintain this space here between the femoral head and the acetabulum, the ball in the socket, or is there a lot of gapping or a lot of extra movement? And one thing that we actually found, which was interesting in this still on the right hip, is she has what's called a positive cliff sign. This is a radiology finding that is actually related to what we call micro instability. Okay, so not gross instability where the hip is dislocating, but a micro instability where it's actually moving around more than it should, which is also related to loose ligaments. So she has a positive cliff sign in that the ball of the femur kind of dips down, like you kind of see this little dip here, and the ball doesn't fit this whole circle. On the left side, you see here how this ball fits the whole circle. She does not have a cliff sign on her left side. So she may actually be a little bit more predisposed to getting hip instability on that right side because of that. In many cases, chronically painful joints may have more than one pain generator. So years prior, this patient gets an MRI that shows a labral tear. The surgeon does a labral surgery. Well, it didn't help her pain. She didn't come out of the surgery with any less pain than she went in with. And so we have to think more so like what else could be happening, even if it's not showing up on the MRI. Because a lot of times these ligament injuries or this micro instability, it will not show up on a standard static MRI. The other point I just want to make is don't give up. This patient she'd had surgery, she'd done physical therapy, she'd done a lot of things to try to help her case, and nothing was helping. She wasn't meeting any goals or improving her condition. So it gets very frustrating, right, as a patient to go through that, but don't give up, keep seeking answers.